All right, good morning, everybody. Today we are going to be doing a fall preview based on some of our forecasting and research around COVID. So if this is your first time, we have done a number of webinars on COVID and different impacts and sort of different perspectives on the impacts within communities. So today we're going to focus on what is coming up, some of the different characteristics, some of the things to keep an eye on, and some questions that we've been getting from folks. So a little bit of housekeeping before we dive in. This is a one-way webinar. So the best way to ask questions is through the chat and the questions tab. So as we go through here, feel free to put questions and items in the chat, and we will take some breaks throughout the presentation to answer those. Also, always interested in feedback. If there's topics or other areas that you'd like us to explore, please let me know. And then the last piece, we will send out slides and a recording of the webinar at the end if you have registered. So you'll get an email with both a recording right after this, and then a follow-up email with the slides as well that you can share with folks. So a little bit about us and Data Contours. We are a data modeling firm. We got started doing COVID modeling, but also do a lot of community health, social determinants, population health data modeling as well. So the COVID piece is certainly salient, but we've done a lot of different projects, a lot of needs assessments, working with various types of data. So what we'll talk about today, first and foremost, kind of big picture things. What have we noticed? What have we learned? We'll talk about some things to consider for the fall. We'll talk about specifically some projections that we've got around kind of upcoming peaks, what we might, how we might think about that, what to look forward to. And then we'll talk about also the flu, what is likely to be the situation with the flu, and then how we might, think about and prepare for all of this. So what do we know? We split this into a couple of different parts. So the first thing is there are some things that are the same from the fall. So the first, COVID continues to be a thing, right? It's pervasive. It's endemic within most communities in the country at this point. And so it's spreading naturally throughout the community. And we don't really know where. It's hard in most places to track these infections back to a common source. And that's kind of the hallmark of community spread. We also know that vulnerable populations are still highly disproportionately impacted, 2 to 7 times worse health outcomes than non-vulnerable populations. So and those are largely people with comorbidities, people below the poverty line, people without access to healthcare. We know that adherence to policies like social distancing is still inconsistent across the country, and even within communities and across age populations. And so continuing to get adherence is a challenge, and likely will be going forward. And then this idea that community spread remains high. Still see, in most places, sort of greater than 40% community spread amongst new infections. And that's, again, where the source of the infection is unable to be determined. So, overall, unfortunately, to the frustration, I think, of most people in the public health and epidemiology worlds, really haven't seen, the types of improvements in the situation with infections and spread that other parts of the world, most other parts of the world have seen. Some things are different and or better. So though the overall prevalence of COVID really hasn't improved and is likely going to get worse here, we have seen within mortality that mortality is going down, and this is largely because treatment and care of people with COVID has improved. So when you're hospitalized, we know a lot more about things to do that can be successful in reducing mortality. So prone position, for example, is a really simple thing that pretty dramatically improves outcomes for folks who are having trouble breathing. Um, other things that are different, we do now know a lot more about what vaccines and treatments and drugs are likely to be effective, and those are largely in phase 3 clinical trials. So we can expect that treatment options will increase and become available in the next 2 to 6 months. Timelines are still very uncertain, obviously, given sort of the overall political climate around this. It's hard to make predictions, but given the progression and so far, no huge red flags from a safety perspective with these drugs, though you never know. Likely to see effective vaccines and pharmacological treatments fairly soon. We also do have a better understanding of community spread and how that works, and which populations are more susceptible, which populations have seen higher rates of infection and spread. One of the big things that we're learning a lot about currently is, what groups of students are most likely to see the impacts of COVID. How can we do schooling and group care in a way that minimizes infection? So we know a lot more about that than we did in the spring. And then, most places have successfully scaled up testing, tracing infrastructure. So, the number of tests that we're doing by day today is about 10 times what it was, 10 to 20 times what it was back in the spring. So that's great. It gives us a much better data picture of the spread of the disease. And so, interestingly enough, in some ways, the U.S. today is better off because we've had so many infections, and certainly from a treatment perspective, within the medical community, there's a lot more experience dealing with COVID because we've had such high rates of infection. So it's an interesting upside to an otherwise fairly grim picture. So as we look forward, what do we know? Well, things are likely to get worse. There are a ton of unknowns about what impacts actually will be on COVID or on communities because of COVID in the fall, but we do know some things. So overall, the experience that we've had with COVID has been under, in some ways, better or ideal circumstances. The weather's been good. It's been possible to balance the risk and challenges with community spread and policies, so we can keep businesses open through outdoor seating while still restricting or still limiting the spread of the virus. As we go into the fall, a lot of those options that we've had over the last 6 months aren't going to be available. So we're already seeing this with schools where, for 3 or 4 months, I guess 5 or 6 months, kids were out of school. And now, like we've seen in Boston, where they're trying to go back to school, in New York, shutting schools down again, where we've had high rates of infection. So, there's a lot of factors that are going to be changing for the worse in the fall here. It was broadly this pattern we notice, which is immune function is reduced in the fall and winter. It's not totally clear why, but flu and colds and other infections spread more rapidly in the fall and winter, and so we will likely that dynamic see increase in COVID infections, whether it's because there's really an immune response mechanism or just because people will be inside and there's more opportunities, probabilities of infection, result is kind of the same. Then there's the compounding effects of flu on utilization and care. And so, both because people with the flu will be taking the same resources as people with COVID. If we see an equal level of flu spread, you're basically doubling the care requirements for people with respiratory distress. But there's also the possibility for people with COVID to also get the flu, and so this compounding effect is true both at the system level but also at the individual level. And then, broadly, we've been going through this for a long time, so I think everybody is pretty fatigued with um, the policy prescriptions that we've had to deal with, shutdowns and virtual school, or limitations on childcare, et cetera. And so overall, we do notice that adherence is going down. People are taking social distancing less seriously. And as the options for alternatives decrease as we go into the fall and the winter, like outdoor activities, we would expect that adherence continues to go down. And then there's all the the other considerations around just the political climate and going into a high level of uncertainty generally. So not a super rosy picture. Unfortunately, the upside is potentially, treatment options and vaccines become available sooner rather than later, and that gives a whole lot more options for reducing the spread of COVID within communities. But other than that, there's not a ton of light at the end of the tunnel yet. And we've talked specifically about COVID from a disease perspective, but there's a broader set of implications for communities, and most communities have already felt the impacts of COVID. In our modeling, we've seen anywhere from 2 to 3 times the level of unemployment and new people in poverty over the last 8, 9 months, as we typically see. So, in most places, the unemployment rate last year was around 3 or 4%. Right now, current estimates are anywhere from 7 to 12 or 13%. So, significant levels of community impact. And again, the downside risks are I think much greater than the upside risks of things getting better. So, the couple of factors we've seen, this week, it's looking increasingly likely that there will be no additional economic stimulus until January or February, possibly after the election, but the likelihood of a lame duck Congress passing significant fiscal stimulus is still pretty low. So we'd be waiting, optimistically for a new administration and a new Congress to pass some sort of fiscal stimulus. We're continuing to see increases in long-term unemployed. So the number of people who have been out of a job for longer than 27 weeks continues to increase as we go week by week. The level of continuing unemployment claims across the country has stayed relatively stable. Unfortunately, for the last last 4 to 6 weeks, and we would actually expect that to go up here as we get into the fall and with the new rounds of layoffs that have been announced in the last week. And additionally, there are the potential for these sectors that have been hardest hit from an economic perspective: food service, healthcare, accommodations, education, to see another round of furloughs and layoffs if we see additional shutdowns or restrictions on business activity in the fall. And then finally, there's this big cliff of reduction in UI benefits that really hasn't been backfilled in most places at the end of July. We're now coming on about 2 months beyond that, and we're really starting to see the impact bubble through in people who have burned through their savings that they were able to accrue because of that additional money. So again, we would expect through the end of the year, as places have eliminated protections against foreclosure and evictions, that the number of people who are homeless is going to increase. Already, the number of people who are food insecure, relying on outside assistance, has more than doubled in most places. So the economic picture, barring something unforeseen, again, really, sort of trends toward the negative. So this is, a little harder sometimes to really understand than the COVID numbers, but broadly, the economic damage that's been done under the behind the scenes, I think, is going to be the bigger long term picture for most communities than necessarily the immediate effects of COVID. Okay, so as we think about all this, the really big question going into the fall is, whether we see the gains from treatment outpacing the increase in infections. So if we're able to drive down the rate at which people are hospitalized more quickly than the rate of infection is increasing, we can sort of flatten the curve, right? And that's going to be the question that's really open. Is we've not done a great job flattening the curve from an infection standpoint. It's been better from a mortality standpoint, but even with the wind at our backs, it was challenging this summer. So with all of these other factors that are going to make this even more challenging in the fall, are we going to see the increase in the rate of infection outpace treatment and benefits in treatment? And if so, what are the likely impacts on the hospital care and all these other factors? So we're going to walk through some broad modeling for what we might expect for infections in the fall here. But first, wanted to pause and see if anybody had any questions, just kind of about the high level takeaways that we've seen for the fall. Again, you can use the chat or the questions tab if you'd like to add anything in there. Okay, so what can we expect for infections coming up? There's a couple of dynamics to think about as we go into the fall here, and the first thing is this is the curve of positive tests that we've seen over the last 6 or 8 months. The couple of things to notice, we had the initial peak in March and April. About half of that was attributed just to New York City and suburbs. Most places in the country really didn't see much of a increase in infections in March and April and May. However, we reached this trough after most places shut down. We saw, really widespread reduction in the prevalence of COVID within communities. Unfortunately, most places probably opened too early. We have this 3 to 4 week lag in seeing an uptick in tests and maybe a 6 week lag in mortality. The story everybody's familiar with is mid-June, late June came around. We started to see this increase in infections that led us to a new peak at the end of July and August. And that new peak was around 60 to 70,000 new cases per day. So the story that we've seen, unfortunately, going off the peak in August into September, we've not seen the same level of reduction in community spread that we saw in June. And so that's concerning for a couple of reasons. The first is, we have this widespread reservoir of COVID infections across all communities now. And so that makes any sort of intervention really difficult because testing and tracing only works when you can really trace the origin of infections, and when it's widespread community spread, it's really hard to do that. So we're starting on the back foot already. The other really concerning thing is just the level is almost double what it was in June. So because the infection rate of spread is actually exponential, the two times level of community spread we're seeing right now would lead to potentially a 4 times peak coming here into the fall. And so the concerns around what's the next peak, just purely from a kind of a math perspective, epidemiological perspective, we would expect something to be in that 2 to 4 times range. And so obviously, hopefully we'll get much more effective and targeted at NPIs coming in. Mask wearing, we've seen a pretty big change even over the last couple of weeks in perceptions around mask wearing outside of the home, which is great. So, hopefully it goes down. But again, the rate of the trough that we saw the last time being so significantly higher than what we saw in June is a pretty big cause for concern about what the future peak might be as we continue to see the rate of infections increase. So, our forecast, again, the previous daily peak was about 70,000 in late July and August. So, we would expect the likely daily peak in positive tests in the fall here to be in the 140,000 to 280,000 range. Hopefully, again, it's sort of towards the low end of that, but we'll see. So, some thoughts behind that, and just kind of gut testing that number because it seems really high. However, given the increase in testing, that number would still represent about a 10 to 20% positivity rate, which is what we saw in the summer in places like Arizona, Texas, and Florida, when they were seeing these outbreaks happen largely in urban areas. They were in that 10 to 20% for weeks on end. So there's some interesting dynamics actually between southern states saw in the summer as the weather actually was, for those of you that have lived in those areas or live in those areas currently, it's kind of the inverse. When it's super hot and muggy outside, it drives people inside into air conditioning, which is, kind of the worst dynamic for COVID spread. So, we might look at those as models for what we would see. The 20% positivity rate was pretty consistent. So, that 140 to 280K, given we're over 1 million tests per day right now, that seems about right. So, one of the really significant open questions is what's the length of immunity? We know with other coronavirus variants, it's 6 months, which is why you can get the cold more than once a season, or certainly more than once in your lifetime, and the flu as well. So the open question is kind of how long does immunity to COVID after you have been infected last? And now that we're 6, 7, 8 months after the initial period of infection in some communities, we're going to get some really good data about that. New York City is going to be one of those test cases, given some of the estimates, and in some parts of the city, they were seeing seroprevalence of antibodies at greater than 30%. So more than a third of the population had a COVID infection. Now, 6 months later, it's going to be really interesting to see what that number looks like. So, one of the challenges, I think, from a public health perspective, has been an implicit assumption that immunity lasts a fairly long time. And if that's not the case, that would certainly be a pretty big reason for concern in both, overall kind of care utilization, but also, some of these questions around community spread. And in particular, if people have a feeling like, suddenly they're immune, but in fact they aren't, that raises some pretty big concerns from a policy and intervention standpoint. Um, and the interesting sort of overall takeaway is also, regardless of individuals, we still see infections on the rise everywhere, not just in places which have not experienced outbreaks. So again, places like New York and the Northeast that went through the majority of or represented the majority of the cases in the spring are seeing increases in infection rates similar to everywhere else. So where that stops and what the ceiling is, again, is going to be the big question and really determine what the overall increase in cases looks like. So we'll talk about deaths too. Deaths follow a slightly different pattern that we've seen. The mortality curve is almost the inverse of what we've seen with the infection curve. So the initial surge of infection in March and April and May led to a much higher rate of daily deaths than we saw in the peak that we had over the summer. And there's a couple of thoughts behind why this is the case. The first is that treatment has gotten better. So people who are hospitalized die at a lower rate today than they did back in April, both because hospitalization rates have been lower in a lot of the country, but also treatment has gotten a lot better. We talked about earlier, we know a lot more just because we've treated a lot of cases within the hospital setting. So your odds of dying have decreased each month that we've gone on. So that's good. There's also the opportunity or the possibility that we'll see more widespread availability of some of these treatments within the clinical care setting that can help reduce the mortality rate and reduce overall utilization, which would be great. So some of the questions are similar. If we see the previous low in July, and again, deaths tend to trail the rise in positive tests by 2 to 3 weeks. So the previous peak, kind of August into September, was about half of what we saw when in March, and the slightly higher trough that we're in now is still, it's actually pretty close to what we saw in June. So it's about 1.2, 1.3 times higher. So that leads us to think, okay, we're going to likely see a lower mortality curve going forward, and the peak is not going to be increasing at the same rate that we see the test positivity rate increasing. So that's good news, definitely. So given that, we would expect the previous peak of about 1,500 deaths per day over the summer. Going into the fall, a reasonable estimate is going to be 2,000 to 3,000 per day, which is still an astounding number in some ways, but it's certainly not the 4 times number that we think would be reasonable for increase in test positivity. So some thoughts about this. One of the other dynamics that I forgot to mention with the mortality spread is largely the increase in spread amongst less vulnerable populations. So what we saw within the spring of a lot of outbreaks within elder care facilities within vulnerable populations over the summer. the overall average age of infection decreased from like mid 40s down into the 30s, which indicates that a younger population that largely is going to have less effects, or feel less effects of the virus. So, that also is an open question whether we see that average age increasing again. Does it go down again? But that's going to help determine what the mortality curve looks like. The more spread happens within older populations, the higher the mortality is going to be. The more it happens within younger populations, the lower it's going to be. The big question, outside of just the disease spread, is going to be overall, what are the surge in care requirements going to mean for overall care and capacity within health systems? We saw within New York City, a large increase in mortality was due just to people unable to receive care. And some of the estimates of actual population level mortality is 2 to 3 times what the reported rate was, because people were just dying in their homes. They were unable or unwilling to go to the hospital. And so that is, I think, a big open question, especially as we consider dynamics of flu, is what the potential for overall care utilization is going to be. And again, the closer we get to that capacity limit in these surges, the higher the mortality rate is, or we see the mortality rate, your likelihood of dying increases if obviously if care is or hospitals are strained. Okay, before we go into the flu, I know there's been a few questions, so we'll pop in. Okay, first, is it safe to say that we might expect a 4x peak? I think on the conservative side, certainly a 4 times peak, I think is appropriate for planning purposes. So if you want to look at a worst case scenario, I would say 4 times. I would say the best case scenario is maybe 1 to 2 times, and likely is maybe somewhere in the middle. But I think given the elevated level of community spread, it's hard to see how we don't avoid a peak in the fall that's bigger than the one we saw over the summer. So the real question is what the degree of that is. So the other question, is there any tracking yet on long-term health effects of those who have had COVID? Some long-term, it sort of depends on what your definition of long-term is. For most people, the longest they've been able to monitor folks has been 6 months after infection. And, the numbers I've seen are anywhere from like 10 to 30% are still feeling some sort of symptoms after, months, 2 to 3 months after infection. It'll be interesting to see some of the results from some of the data from these phase 3 clinical trials, because they are going to be capturing some of that data. And, ideally, these clinical trials will be going for years beyond the final dose to capture some of this data. And so that I think is going to be the question. Is are there, and for which populations? There's been a lot of sort of qualitative anecdotal evidence around inflammation of the heart, potentially as a long-term side effect of this. There's been, I've seen some anecdotal reports around sort of neurological impairment of various kinds. Recently, big conversation around cognitive impairment because of COVID. So it'll be interesting to see. Then how does the short immunity length impact vaccine development? It's an open question. I mean, that ideally should be one of the endpoints that they're looking at as part of the phase 3 trials, and obviously are. Again, that's going to be determined by how long they run the phase 3 trial. So the longer they run it, the more they're going to be able to see what the immunity profile looks like. I've not seen anything yet really conclusive. Again, because the longest infection that we've got is about 6 months right now, or post-infection record. So they're really, this is kind of the big open question from a population standpoint, is how long are people immune? And then, the thing we also haven't talked about is what happens if the virus mutates. And so, we did see in the spring, we saw a couple of different variants. There's an Asian variant, a European variant that looked significantly different, both from an infection profile, but also from a severity profile potentially. So, that is an open question: is do we see a COVID variant emerge here as the rate of infection increases? The probability that there's a mutation increases as well. And we don't, nobody can really predict what that might look like. So if you looked at death rate patterns by age, yes. So across the board, mortality rates are going down. So it doesn't matter whether you're young or old. It's always been very low if you're below 50. So if you're above 50, your risks are significantly higher of being hospitalized um, or of dying. But the mortality figures have gone down pretty much for everybody, and that's largely due to care. Okay, great questions. Anybody else? Any other questions kind of around the infection or mortality figures? Okay. So what about the flu? Okay, so what do we know so far? The tracking stations in the southern hemisphere and their seasons are flipped. So they are coming into spring as we were going into fall. Overall, in South Africa and Australia, there really wasn't much of a flu season. So that's good news. The caveats are it's South Africa and Australia, so low population density, different spread characteristics than what we see in the northern hemisphere. But generally, it's a helpful data point that they did not see a severe flu season this year. That's good news. So other dynamic is now that we've been through COVID and we're doing all these things like mask wearing and hand washing and business closures to some degree, is that going to help with flu as well? And likely yes. There's good anecdotal evidence that overall rates of infection amongst vulnerable populations have decreased. It's interesting. I was talking with our pediatrician a month ago, and they've had no. He was saying they had no cases of ear infections since May. So for 4 months, he didn't see a single ear infection, which is uh, never happened before. So I think there's a really good chance if we continue to see good adherence to these NPIs, that will drive down the rate of flu infection because it spreads basically the same as COVID. Um, but we don't know. And there's so many open questions around that it's hard to make any definitive judgments. It's also unclear what flu spread would do as a potential comorbidity for COVID. So if you get COVID and the flu, and at what rate would people get both of those viruses? What does that do to overall health outcomes and mortality? So it's a big open question there. It's not too likely, but certainly, in the numbers we're talking about and the rate of spread we're talking about, it is certainly something to be concerned about. It's unclear what current vaccination rates for the flu will be. Some of the latest research, Pew did a study, I think, that showed, less than 2/3, somewhere around 50% of adults were planning on getting a flu vaccine this year, which is down like 15 or 20 percentage points over previous years. And that's really discouraging. So if, overall vaccination rates are low, both, that's not great. That's not a great sign for any future COVID vaccine, but also, that increases the rate of community spread for flu. And it's not clear, we never really know until after the fact what the effective of the current year's vaccines will be and whether they have picked the right strain. So there's probably more open questions around the flu than not at this point. The other thing is the flu season peaks in February, so we really won't know until March or April if we get off the peak how this year's flu season compares to previous years. But we can look back at previous years and make some guesses about what the likely flu impact would be. So typical year, we see 35 to 60 million estimated symptomatic flu cases, which is somewhere between 10 and 20% of the population. In bad years, this can get up towards 100 million. But generally, I think last year was about 35 million. That's a big number, and this is symptomatic cases. So the typical deaths that we see somewhere between 35 and 75,000 per year. And again, one of the big talking points in the spring, I guess debated points, unfortunately, is COVID more fatal than the flu? And the answer is yes, by a factor of about 10. So we would expect, given the same rate of infection that we see with the flu, we would expect COVID deaths to be about 10 times this. So, we're getting close to the low end of that number in 6 months, which is unfortunate. But also gives us some guideposts through which we can potentially think about what the flu impact might be. So if, an implication of this is if we're as good at managing the flu as we've been at managing COVID, we would see 20,000 additional deaths per year from the flu than we would see otherwise. So really, not significant. If flu ends up being more prevalent, more infectious for whatever reason than COVID, we would see a higher mortality figure. So we would see, 25% of the COVID figure. So COVID will still be, from a mortality perspective, much more significant than the flu. The bigger concern around flu is what does it do for care requirements? Because though the mortality rate for flu is about 10 times less, especially within vulnerable populations, for the hospitalization rate, it's not 10 times less. It's maybe 5 times less. The thing is, we're really good at treating flu once people are in respiratory distress and they're in the hospital. We have Tamiflu. We have other antiviral medicines that are effective against flu to help with treatment. So whereas in COVID, the average hospital stay is somewhere between 10 and 15 days, so that's going down. With flu, it's like 3 to 5 days. But that does raise the open question of, if resources are going in a typical year, if they're going to treating 500,000 people in the hospital for flu infections, that's 500,000 beds that aren't available for COVID. So the big question generally, as we think about it for the country, flu is probably going to have a moderate to light impact on overall infection rates. Again, there's a lot of dynamics we don't understand. Are we more effective against flu? Are we less effective? So it's a big open question, but I think generally it's safe to say we probably see moderate to light impacts. The question is going to be around hospitalization rates. And again, within most of the population, we see hospitalizations and deaths as significantly below the COVID levels, even given roughly the same spread. So I think it's an interesting dynamic, but I'm not sure in most places, unless you're already getting close to capacity within healthcare systems. Flu is obviously going to be a significantly confounding factor, but where there is a lot of capacity within healthcare systems, the addition of flu is probably not going to tip you over into a situation where you need surge capacity. So that's the initial thinking. All right, I'll pause there, see if there's any questions around flu. Okay. So, what are the current flu vaccination rates? Are they higher than usual? I don't know yet. The flu vaccine's only really been widely available for about a week, maybe two in most communities. So I don't think we have really good evidence so far. And then yes, typically we would see somewhere 60 to 70% flu vaccination historically. So, and again, that's community dependent. But um, Okay. Any other questions around the flu? I know this is definitely something a lot of communities are thinking about, and certainly trying to plan around. So happy to answer any other if we didn't cover a point that you'd like us to. Okay, well, wrap up with a couple of questions. So, are we likely to see shutdowns again? I would say yes. However, they're going to be different in a couple of different ways. I think people are pretty tired with shutdowns. So, I mean, again, we're kind of seeing this in real time in New York City, where Governor Cuomo is being much more assertive with the parts of the city that are starting to see outbreaks, like in Brooklyn. And so, we're starting to see school shutdowns, business closures. So I think it's inevitable that we see some level of shutdown. The big question is going to be what is that level and how targeted is it? Just like on the from a care perspective, we've gotten better at predicting, better at managing the disease from a public policy perspective, a public health perspective. I think we've also gotten better at managing it. So, in the same way, uh, well, I don't think widespread shutdowns at the level we saw in the spring, and home isolation is probably likely. I would be surprised to see that, but I do think we're going to see high risk establishments like gyms and bars closed again, where there are outbreaks. Schools are the open question. Boston is starting to shut down schools again. It's not a great sign. It's also, I think, going to be much more geographically targeted. If you remember back in the spring, testing was so low, there was no way to really nail down even kind of where the hotspots were within a city. We're doing so much more testing now that the ability to show where these hotspots are and where they're coming from down to the zip code level is much more prevalent. So that gives policymakers, I think, a much more fine-grained tool to use in crafting these shutdown orders specific to the locations where they're likely to be impactful. So we've seen that in New York. Again, they're kind of focusing on zip codes and trying to target. The downside is, unfortunately, as we've seen with the White House, once you've tested positive, you've probably already been infectious for 3 to 4 days prior. So there's a little bit of the cows in the field already outside of the barn. You're trying to close the barn door. So there's going to be some challenges there. And again, if that gets out of hand and we really see the dynamics of the spread within the community explode, then you would start to see more widespread shutdown orders. But this would be, my take now, probably moderate. It's going to be pretty focused and focused on those establishments that are highest risk for spread. So what do we need to do today? Last slide here. I think as we're trying to do norming people to the downside risks and how challenging things are likely to be. Again, the factors that we're facing going into the fall are in most ways harder than they were over the summer, and so are more negative, more predisposed to higher rates of COVID spread. So I unfortunately, I think there's a lot of complacency, and I think there's a lot of fatigue, and I think there's a lot of contradictory information right now about kind of what the story is likely to be coming up. So I think norming people, especially decision makers, incident commanders, public health departments, to the potential that we're going to need to make some hard decisions again is going to be incredibly important, and to start communicating that with the public as well. and that's incredibly difficult right now, given again the overall kind of political dynamics. But um, our perspective has always been conservative planning, emphasizing the downside risks where appropriate is better in the long term than trying to avoid those discussions. So, um, I think the last point there is, again, the data is not great, and what we do see is laggy. So, the short term version of what we see, both from a COVID perspective and from a economic perspective, is not accounting for, not representing what the long term impacts are likely to be. So, the curve that we're at today, you can bake in the infections in 3 weeks because those have already happened. So when people are going to start showing symptoms in 2 to 3 weeks, they're getting infected today. So there's this, we see continuing challenge for folks within the decision making world or the public health world, to be thinking 3 to 4 weeks in the future and making decisions based on that with confidence, rather than kind of what the things are today, what the numbers are today. So, really thinking about that time horizon of 30 to 60 days right now is probably more important, than just looking at the current case counts. Okay, and then the last thought, how can we help? We're here to help. We do a lot of COVID modeling. We're able to provide modeling down to the city or neighborhood level. We are, just as we talked about today, we have some new modeling capabilities for projecting what flu capacity numbers are likely to be, on top of COVID projections. So if you're trying to get a handle on kind of system level capacity needs for the fall, we can definitely help there. And then we have our local COVID forecasts up, at the link. And again, we'll send out these slides after the presentation. So we've got a few minutes left. I'm happy to take any questions here. I see there are a couple. So thanks for speaking about schools. Yes, there is a lot of confusion. So I have two young kids myself, and I feel the frustration most parents have about the whole situation around childcare in schools. So it is, one of the things that is probably most challenging about this. So we'll see. I think different parts of the country are approaching it different ways, and we're kind of getting real time information on what works and what doesn't. Okay, what trends are you seeing with employers allowing remote working to continue on a widespread scale? Pretty good. There's a couple of numbers we've seen. One of the ones that was most sort of shocking to me was the estimate of, for New York City, the current occupancy rate, which was the number of businesses that have employees working in their offices, was estimated to be 10%, which was incredibly surprising to me. So I think there are a lot of companies that, I've not seen any large companies that have, said any sooner than January. And I think increasingly we're seeing more and more saying next summer would be the earliest, if at all. Remote work has really changed, the dynamics of employment. And so it's an open question as to how long term will those be, what will the kind of the downstream impacts be. But I would expect, honestly, I think schools that are shut today are going to stay shut through the school year. They may, I mean, April, maybe March, but I would be really surprised to see most places try that currently are not doing in-person instruction to bring it back, by the end of the year. And then for businesses, I think it's, as long as schools are uncertain, it's going to be the same story for businesses, given, it's hard to require your parents to go to work full time in an office when their kids are home. So, again, conservatively, I think next summer is probably realistic for widespread business reopenings. The other factor is going to be vaccination rates against COVID. And the latest estimates I've seen are optimistically next summer, June, July, as when vaccines would be widely available and distributed to the public. And we're talking three quarters, so 9 to 12 months to fully vaccinate the U.S. population, optimistically. So there's a lot of uncertainty. Overall, this has gone on much longer than anybody expected, and I don't see. We may see, if we get a change in administration, we may see those dynamics change in the spring. But um, I'm not terribly optimistic that the U.S. policy response is going to get dramatically better anytime soon. So the effects of this are likely to go on longer than we think they are today. All right. Any other questions or thoughts? People, a few seconds here. Okay. Well, finally, just want to thank everybody for taking the time. Hopefully this was helpful. We'll be doing future webinars as well. So again, as we said at the beginning, if there are topics that would be helpful, and again, if we can be of any help on either the COVID modeling or community modeling, if you're trying to do a needs assessment and looking for the latest information around poverty or unemployment or health outcomes or social determinants within your community, definitely reach out, because we have current estimates based on some of the newer data and newer indicators, so we can help out there. But really appreciate everybody taking the time, and we'll talk to you soon.